Hello and welcome to Health Affairs This Week. I'm your host, Jeff Byers. We're recording on Tuesday, May 13th, 2025. I know I've talked about the May 29th event for insiders on the changes at the FDA coming up quite a bit. Sign up for that. But today I wanted to highlight that next week we are releasing, as part of our insider program, our first trend report for insiders. It's on the use of AI in healthcare, and you don't want to miss that. In addition to the report, you get access to all the exclusive events that we host, as well as different newsletters we publish on drug pricing, the economy, and more. Sign up. If you are more into free stuff, what's your deal? But also we have a free event on May 27th with Clifford Coe and Catherine Ornstein titled, How Can the New Age-Friendly Hospital Measure Transform the Inpatient Experience? Sign up for that if that's also of interest. Today on the pod, we have Katie Keith to discuss all the different goings-ons in the administration this week. It's been a big week, as well as some recent happenings. From the Big Apple, Katie Keith, welcome back to the program.
Thank you, as always, for having me.
Yeah, so you're in New York currently. What are the streets saying in New York? Are they talking about health policy?
They might be, but certainly not as much as D.C.
Yeah. So speaking of, great transition to, what's happening in DC. So we are going to talk about, it is Tuesday. There's been a lot happening on the regulation front for proposed rules and markups and text is being released. And I'm not really familiar with it all, so that's why you're here. But before we get into that, I wanted to talk about the current state of rulemaking. So earlier this year, HHS announced it would reverse soliciting public comments before it issues regulations affecting government benefits and grants. What can you tell us about this?
First, I would say well done. That was a good summary. What you're referring to is called the Richardson waiver. It's called that because it was put in place by then Department of Health and Human Services Secretary Richardson under the Nixon administration. So we are talking about a policy that has been in place for about 50 years. That Secretary Robert F. Kennedy Jr. rolled back in February of this year. And what that policy had done, and again, it had been maintained by every administration since Nixon, was really say HHS prioritizes public comment. We want input from the public. We want to give notice before we make changes to things like public benefits and contracts and grants. Even if we don't have to, under this law called the Administrative Procedure Act, we should. And it was sort of internal HHS policy that said we need to give notice and allow an opportunity for the public to give us feedback before we make changes that can affect those sort of categories. And I wrote about this. You can see more of the details there. The other thing that the prior Richardson waiver policy had said is it's sort of disfavored to invoke what we call the good cause exception under the Administrative Procedure Act. So, and maybe the step back is the APA, the Administrative Procedure Act, is a law that gives you the rules about the rules. It lays out all the requirements that agencies are supposed to follow when they are changing federal regulations. It's, an agency will typically publish to give notice to the public and then take comment for, there's no set period of time, but generally, let's say 30 or 60 days. Then when they finalize that rule, they have to, review those comments, generally respond to them, and finalize the rule. And it's, the idea is that transparency improves the rulemaking process. It gives the agency feedback, especially from those who are going to be most impacted, whether it's patients or healthcare providers or insurance companies or states, for example. So healthcare is extremely complex, as all of your regular listeners know. And the idea that you could make these changes without letting someone know in advance or giving the opportunity to sort of be heard or get more data or get more feedback is really, really challenging. And yet that is exactly what sort of pulling back on this Richardson waiver is doing at HHS. We haven't yet seen, speaking for myself, I haven't yet seen HHS leverage this yet. They have not sort of pulled back on a ton of things yet. I have a couple examples that I can give, but I think more is coming. And so we could talk about that as well. And then maybe we're going to get to this, but this is not only just happening at HHS, it's really happening kind of across the agencies due to some pretty high-level directives from President Trump.
Yeah, I do want to ask about some of those public comments and about the state of those. But before that, you wrote in Health Affairs Forefront about, from a broader perspective, about a presidential memorandum that encourages federal agencies to be less transparent and sidestep public input on major regulatory changes. Is that any different than what you're talking about from HHS, or walk me through that?
No, it's quite similar. So really, I think this is a Trump administration-wide project. And I think the president, and I would say the director of the Office of Management and Budget, I think clearly have a vision for a deregulatory agenda that they want to see across the board. And so far, they've been extremely aggressive at, say, the Department of Energy. Even the Department of Justice has already rolled a lot of things back. The Consumer Financial Protection Bureau, the CFPB, has rolled a bunch of things back. I'm still waiting and watching for a more significant impact in healthcare, but I think it is coming, which is why I was so excited that you wanted to talk about this, because I think there is a cloud of this deregulatory agenda really hanging over the policy that the Trump administration is going to do. And what it means is they're moving extremely quickly. I think that is the part for listeners to really pay attention to. If you don't have to do this, or even try or attempt to do notice and public comment, you can just be putting out what we call interim final rules. You can just be revoking policies. And so what we're seeing examples is just short notices being published in the Federal Register that say, here's the 20 things that the Consumer Financial Protection Bureau is pulling back today. And no one gets to say anything about it. You shouldn't rely on it. And in the meantime, the agencies aren't going to enforce it either. So it could be extremely disruptive without any opportunity to weigh in.
Yeah. So going back on that, what you mentioned a vision, what is this vision, or what's the purpose of this vision?
I think it's a deregulation writ large, and it's probably an ideological vision. And I'll give one example. A different executive order that the president signed is a requirement that agencies that want to do new regulations have to pull back or identify 10 regulations that they don't want anymore, that we call it sort of the 10-for-1 executive order. So that is not the most rationalized thing in the world. It is purely a numbers game of we just want fewer regulations. So I think that is part of the approach and the vision. During the first Trump administration, they had a 5-for-1 regulation EO, and here they really upped the stakes by taking it to 10-to-1. And so we're still kind of watching to, again, see how that will play out. But you're really seeing it across the board for different industries. President Trump signed an executive order recently specifically to say, I want you to repeal this Department of Energy rule that defines showerhead in a certain way. And you should have no notice and comment, and that change is going into effect in 30 days. So those are the types of examples that we're seeing, very, very specific. And I'm waiting for that to come to the healthcare world.
Yeah. So on the public comment thing, question, it's going to be a roundabout way, and just to get to how helpful are public comments? So, we all know about if you're a listener of a certain age, the Bodie McBoatface scandal. I don't know if it's a scandal, but event where the public named a boat. There was a public contest, naming contest. Here in Richmond, Virginia, they had a naming contest for the baseball team, Richmond Flying Squirrels. I'll let you decide if you like that name. But there's been talks, so there's that of just people kind of messing around with comments. Generally, I would imagine some of these people are more informed than the general public if they're commenting on regulations. But people that are definitely more informed are potential lobbyists. So there has been some talks about a bunch of comments from lobbyists in these public rulemaking. So how helpful is this process from what you can tell?
Yeah, helpful seems like a value word. What I will say is I do think the comments make a difference. And I found that being in government myself. I don't know if they will make a difference to this administration that seems very, intent on doing what it wants to do. And I could give some examples where the first Trump administration received, I think, probably hundreds of thousands of comments and didn't change a word in the final rule, that kind of thing. But I do think the comments are valuable, if only because they put people on notice of the changes. And then it's an opportunity, I think, especially for, you sort of mentioned lobbyists, but I think industry comments are often helpful to talk about the burden to, government agencies only know what they know. And so giving more of that sort of operational feedback, sometimes it's used to push compliance states out to give more industry and states and others more time to adjust to the rules. Sometimes it results in true tweaks. So I think comments are extremely valuable, in addition to sort of the value of, in and of itself, being able to comment and give your feedback on something that's happening. So there's that sort of intrinsic value to it as well. But I do think that comments can make a difference if they are being considered in an open-minded way. I think what we're seeing the trend across this deregulatory agenda is there's not a lot of interest in taking that feedback or even seeing what it is. And so we'll sort of see where they go from here. But I'm expecting them to get, I think particularly after the collective we, gets through this budget reconciliation process, which I know we're going to talk about, I am expecting, I think, the Trump administration to turn even more full-heartedly, if you will, to rulemaking and rolling back some of this stuff. And I'm expecting them to do a fair amount of it without notice and comment.
Okay, so before we move on to budget reconciliation, is there anything else that you want to talk about from deregulation?
I think one of the reasons I'm anticipating more action from the Department of Health and Human Services on healthcare policies is in part because I know agencies were directed to go through a new process to identify all the regulations that should be pulled back, both because they don't match this administration's policy priorities, but also because agencies have been asked to identify rules that aren't consistent with Supreme Court laws. And so agencies they've been doing that work quietly by themselves. They had to submit a big package and send over their list to the Office of Management and Budget in mid-April. And I think we're beginning to see some of that come to fruition as have been giving examples of other agencies posting guidance, rescinding a whole bunch of stuff there. So I just want listeners to know that there was a whole process that is going on behind this. And I think that is going to be ongoing work that the agencies are doing quietly to identify the things they want to roll back without notice and comment.
Looking to the budget reconciliation, new text was released this week. A lot of things were released this week. There's the drug pricing executive order, which we are not going to get into. A lot of stuff we're watching. What are the top line findings for healthcare policies that's come out? Full stop this week.
What an easy question. So we're recording on Tuesday.
That's right.
That's a caveat. It has already been a very busy health policy week. You mentioned the executive order on prescription drugs that the president signed on Monday. The Centers for Medicare and Medicaid Services also issued new guidance on the Medicare drug negotiation program, which I know some of my favorite prescription drug experts will be writing about for Forefront. There was a new proposed rule on Medicaid provider taxes also coming out of CMS. So there's a ton of activity, and it's only, day two of a very long week. I know I and many other people all around DC have our eyes glued to the markups for the House Energy and Commerce Committee and Ways and Means Committee that are occurring later today on Tuesday. But for this, mega budget reconciliation package that is currently moving through the House, happy to talk about some of what's in there. It is a huge healthcare bill that, if enacted, would represent the largest cuts to Medicaid in the history of the program. At least 13.7 million people will be newly uninsured in 2034 as a result. Lots of disruption coming for healthcare if this bill makes it across the finish line.
Yeah, so let's dive in. You mentioned Medicaid work requirements, and you mentioned the CBO estimates for how many people might lose health insurance based on this. But yeah, what are the details? So I noticed some Medicaid work requirements stuff. I have in my notes capping SDPs, which is a great acronym that I don't know what it is.
State-directed payments.
Thank you. So what's in there?
Another softball on health affairs this week.
Let's start with Medicaid work requirements. What can you tell us about what's in there for that?
Yeah, so a few top lines, and I and others will be publishing on this and on Forefront, so folks can dig in on all the nitty-gritty details. But mandatory Medicaid work requirements so every state would have to do this. I think it would result in huge administrative burdens for enrollees and states to actually administer this program. We know it results in coverage losses, and I think it will be exacerbated by some of the other new red tape that would be being imposed through the bill. So it would essentially require enrollees to show that they are doing work requirements or school or other sort of community engagement requirements for up to at least 80 hours a month. States would be required to confirm that on at least a monthly basis, but they could do it more often if they wanted. They could do weekly checks and, all of the experience. And Sarah Rosenbaum has a great past piece on this, laying out the evidence and data and what we know about Medicaid work requirements shows that, it results in coverage losses because these are complicated requirements to have to follow up on. And we know from data from folks like KFF that the vast majority of Medicaid enrollees are working. This, to me, seems like a huge solution in search of a problem in many ways. And I think it is designed to reduce the Medicaid rolls. in this instance. And I sort of mentioned this, it's not just the Medicaid work requirements. There's a whole bunch of other, again, new red tape that's being imposed. Eligibility redeterminations would be happening more frequently for the expansion population. There'd be a lot more, address verifications and all kinds of things there. So just lots and lots of burdens for beneficiaries themselves. There'd be new cost sharing requirements. So folks would pay higher. So for those who are able to jump through all those hoops already and keep their coverage, you would face higher costs. And, there's a whole bunch of stuff in there on, I think, limiting state flexibility for how they fund and finance their state Medicaid program. So there seems to be this idea that you can lock in what's currently happening, but stop states from raising provider taxes or doing other changes like that. And I think it's going to really tie states' hands going forward, even as this bill loads up on all the new stuff that states are going to have to do to manage their programs there. Two, maybe other things on the Medicaid side to flag, the bill would defund Planned Parenthood. It doesn't say the words Planned Parenthood, but it seems very targeted at that organization, and prohibit states from using federal funds for the treatment of gender dysphoria for kids. So that would be a significant new policy. And that's everything I'm saying is like scratching the surface on the Medicaid front. And then there's a whole bunch of Affordable Care Act changes too.
On the Medicaid front, so again, I don't think I'm a policy wonk per se, but like my cursory reading, so correct me if I'm wrong, that are they putting more burdens on states to enact the Medicaid program in general? And to what end, if that's correct in your reading, just why?
I think it's definitely correct that there will be many more burdens on states. I think it's a lot of paperwork burden. It's a lot of, checking eligibility. It's having beneficiaries come in and report that they're I think the burdens that are going to be placed on states are going to be pushed down to enrollees who are inevitably not going to be able to keep up with this complicated system of what they and we have evidence from this. You don't have to take my word for it. It's when this was rolled out in Arkansas, people lost coverage not because they weren't working or doing the community service that they were supposed to be doing, but because they didn't know or weren't able to submit the paperwork to prove that they were doing all those things. And in fact, in Arkansas, you saw people lose their jobs because they lost their Medicaid coverage. And so it's this perverse thing. So I think the requirements on states are designed to get pushed down to enrollees and again, inevitably result in coverage losses that you sort of mentioned the CBO is already suggesting. And so the top lines just from the Energy and Commerce draft, again, we've got multiple committees doing multiple things. All of this will get wrapped up, but they're moving really quickly, so we don't have a full picture yet. As of Tuesday, the overall Energy and Commerce bill would cut at least $715 billion from healthcare. That's both Medicaid and Affordable Care Act. And they estimate that at least 13.7 million people would be uninsured. More people would be uninsured in 2034 based on this. I'm saying at least very pointedly because I think everyone expects those numbers to go up as CBO is able to continue to do its analysis. There's been certain things where they haven't had time yet to look at, what's the interaction of this Medicaid change with this marketplace change? Because of course, all of this is additive. And so they have said as much that they think the coverage losses are going to go up. The Ways and Means bill has some things that are going to result in, I think, people losing coverage as well. So double-digit coverage losses and, hundreds of billions of dollars being taken out of healthcare if this becomes law.
So you mentioned we're only really scratched the surface on Medicaid. So looking out from Medicaid, just like we're not going to be able to cover everything in this time. So was anything surprising to you in the text of the reconciliation bill?
I don't think anything is surprising in that the top lines of this budget reconciliation resolution suggested these changes had to be sweeping. And I think that's what folks have been sounding the alarm about for a very long time. And I think the scope and degree of the changes is still so overwhelming and significant, even as I read it. I think maybe I had an understanding of what the top line policies would be, but getting the drafts, reading through it, seeing all of it together and trying to understand the impact that would have on patients and states and frankly, state economies and healthcare providers and uncompensated care. And it will, I don't think you can overstate the impact that this would have on the healthcare system. So is that surprising? I don't know, but it definitely felt the impact of what would happen if this becomes law.
So every episode could be someone's first, and maybe this is someone's kind of introduction into health policy world or deeper into the health policy world than before. With that, like, what are the next steps for this package?
Yeah, well, don't let this be your last. If you're listening to this and want to run in the opposite direction, because I would not blame you. Yeah, that's my pitch. There you go. No, in terms of next steps, so again, recording on Tuesday, this afternoon, two of these committees, House Energy and Commerce, House Ways and Means Committee, are doing a, quote, markup of the bill. So there'll be amendments. Some people are suggesting, these could run all night. So we'll see sort of what state those bills are at the end of that process. And then it will continue to move through the House. So there'll be other House hearings. All of that will get packaged together. It will go to the House floor at some point. And then once that's done, it will go over to the Senate. So this is a long slog. I don't think we've seen the end of even the policy changes. And so I think folks should absolutely stay tuned both to the podcast and Health Affairs Forefront, where there will be a ton of analysis as this continues to move through. But much more to come, and sort of what could be a devastating starting point. Let's put it that way.
Yeah, you mentioned Health Affairs Forefront, our digital publication outside of the Journal. This will publish on Friday. On this particular aspect of it, what's in the hopper for you to discuss?
I am certainly I could speak for myself, which is I am working on a very long, wonky, detailed, as is my style, summary of what is in these packages as of their sort of introduction or consideration for these markups. And then I think we'll use that as the baseline to kind of update over time as it moves through the process. Anything can happen. There's already been some outcry from governors about some of the cuts. I think a lot of the hospitals and provider associations are maybe mobilizing against some of the pieces of this, so I am expecting sort of changes over time. Certainly maybe changes by the time this gets through the Senate, which has its own rules that we haven't talked about. But President Trump and Republicans in Congress seem quite motivated to get this done quickly. So, I think count on us here to be doing the quick turn analysis that folks need, recognizing that things will certainly change over time.
Yeah. And what's that word count currently?
Don't ask me if you don't want to know.
Well,
but it'll be linked below, everyone. Yeah.
That's right. Well, Katie Key, thanks again for joining us today on Health Affairs This Week. To you, the listener, if you enjoyed this episode, please send it to the budget hawk in your life, and we will see you next week. Thanks all.